And as people come in, my name is Brian Camerata.
Rich Herman.
And we are here to present an award. So as many of you know, the Anesthesia Patient Safety Foundation annually confers the Ellison C. Pierce Jr. MD Award for Best Abstract in Patient Safety. This award honors the recipients and Dr. Pierce, who is the founder of the Anesthesia Patient Safety Foundation, a past president of ASA, and one of the world's most influential leaders in promoting the patient safety movement. The award also embraces the APSF vision that no one shall ever be harmed by anesthesia care.
Excellent. So the ASA Abstract Subcommittee on Patient Safety and Practice Management, which I chair. So every year we receive many excellent abstracts related to patient safety and quality of care. And our committee, as well as APSF, reviewed a number of outstanding abstracts for this year, but ultimately one stood out among the rest. The winning abstract was co-authored by Drs. Amit Saha and Scott Siegel and entitled Effect of Structured Handover Procedure on Postoperative Adverse Outcomes.
Both authors are faculty at Wake Forest University. Dr. Saha is an associate professor and clinical data scientist. Dr. Saha's expertise and focus in healthcare includes quality, patient safety, and medication safety. Dr. Siegel, who is known to many of you in the room, is a full professor in the Department of Anesthesiology with clinical interests in obstetric anesthesia and preventive medicine. In addition, both authors are involved with the ever-expanding field of clinical informatics.
Excellent. So, well, I get the... So, again, on behalf of APSF and ASA, I'm honored to present the 2023 Ellison C. Pierce Jr. Award to Drs. Amit Saha and Scott Siegel. Please come up.
This it really is.
So take it. It's very heavy.
Put a hand underneath.
Right over here, actually.
Okay.
Thank you. Congratulations again. Well done.
Well, good afternoon. My name is Dan Cole, the president of the Anesthesia Patient Safety Foundation, and it really is an honor today to introduce our speaker for the Ellison Pierce lectureship, somebody that basically is an icon and a pioneer in patient safety. First, what I'd like to do is go over a little bit of APSF. I won't spend but a minute or two talking about APSF and Dr. Pierce, who really is our North Star at our organization. We are an organization that essentially has six actions or six levers that we pull. One is research. We're not necessarily a research organization, but we realize how critical research is to advance the field, and we've submitted or actually produced over $15 million of research over our existence. Education, we are strong believers in education. We have the annual Stolting Conference in September that is free for anybody to attend. This past year we talked about emerging technologies. Last year we talked about NORA. Actually, we had a standalone conference last November on hemodynamic instability, and we hope and have actually produced manuscripts that have been peer-reviewed and generate recommendations. Our newsletter, which actually our guest speaker started, is flourishing and may be kind of the crown jewel of our organization. It is conservatively read by 650,000 people each year. Some estimates even have it closer to 1 million. And in every single country, in the world. It has top quality science and practical application for people. It is free. You can go to our website, sign up for it. There is no print copy, but you can get it. Collaboration, there's a mountain of work to do in patient safety, and we realize that the work is better accomplished when you collaborate with other organizations, and there are a number of organizations that we collaborate with. Communication, we have a strong social media presence. We have a website, apsf.org, which is visited annually by over 1 million people. And finally, we are not really built to produce advocacy per se, but we have helped support advocacy, and we have gotten involved. Our latest is supporting a bill in Congress about opiate safety in the operating room. We are an organization that depends on your donations. So if you feel so inclined, there's this dip jar right outside that you can put your credit card in, select an amount, and somehow that went backwards, and can contribute to our projects. We use our dollars very wisely and judiciously. A word about Jeep Pierce. Jeep Pierce is really kind of our North Star for the APSF. And this is a quote that I paraphrased from him, which really helps guide our organization. Patient safety is not a fad. It is not an objective that has been fulfilled. It is an ongoing necessity. It must be sustained by research, training, and daily application in the workplace. The analogy here is it is really a marathon. It is not a 100-yard sprint and we're done, we claim success and move on. It is something that we do for a long time. A picture of Dr. Eichhorn there at the top, looking over the first issue of our newsletter. You can kind of see it to the right. Jeep Pierce is on the far right, or that would be your far right of that picture. And he was the individual that started the newsletter. He still serves on the editorial board. And let me just start to introduce him via the newsletter. He had, at the beginning, no aspirations to become a physician. He had a journalism career or a writing career in mind, wanting to be the next Ernest Hemingway, as he said. Didn't quite work out, and fortunately for us, it didn't work out. He was inspired by his internist father, and he went to medical school where he excelled. Upon graduation, he stayed at Harvard and began a general surgery residency. Lasted a little while there, but then he decided to move over to anesthesiology at the same Harvard hospital. Did a research fellowship and completed training and started on the faculty at Harvard. And you'll hear a little bit more about that as he gives his talk. He was in the room when APSF was conceived, so to speak. And we will celebrate next year's Stolting Conference in Boston, 40 years to the year from the date that the APSF was formed. It was actually codified in 1986. So we're celebrating 40 years for several years. So, but next year we will be in Boston to celebrate that. He was editor of our newsletter for 17 years. And in 1991, he became professor and chair at the University of Mississippi, and kind of tired of administrating, he decided to move to the University of Kentucky. He now resides in the Silicon Valley here with his family, but is still active. Really, he's received numerous awards, and again, is a pioneer, a scholar, and an icon in patient safety. He is most proud of being the recipient of the 2010 Eisenberg Patient Safety and Quality Award, which is really the Nobel Prize in patient safety. He continues to promote anesthesia patient safety at every opportunity, and there's a few more of his achievements here that are listed on the right side of this slide. I could go over an encyclopedia of career milestones, but I won't, because I know you don't want to listen to me. We want to listen to Dr. Eichhorn. Dr. Eichhorn.
Okay, we need to shift to the other. We're going to figure out how to get to the other presentation. We'll get there.
Do you have to get out of my
I
slides?
guess I think you do. There you go. Bingo.
There you go.
Excellent. Okay. This is one of my favorite slides. I've used it for many decades now. In the days of carousel projectors, it was very important to get the focus right at the beginning. So I did that with this slide. It does, however, today have a particular relevance because it is a good example of the application of modern technology to traditional situations, which is what we're talking about, integrating behavior and technology for patient safety. I have no disclosures because I'm retired. Today, the learning objectives, which are in the program, of course, about electronic monitors greatly enhancing human senses, providing early warning and hopefully early resolutions of untoward situations, integrating signals from all the interoperative monitors into the safety mindset to allow early diagnosis and treatment. But perhaps most importantly, I think, preparation and planning for the future, which is sophisticated, exciting technology that I'm incredibly impressed with. Okay. There we go. GPAIRS passed in 2011. Of course, he was chair of New England Deaconess, ASA president, founding president of the APSF, as we've heard. I got to get my pointer. There it is. He loved this picture. He submitted this picture for many years anytime he needed a picture. This, of course, is what he looked like later in his career. And we just had the award for the best abstract from the ASA meeting, the APSF Pierce Award. And this is the year the Pierce Award was initiated, and I'm pleased to say that Jeep himself was very pleased, as you can see. At the 25th anniversary meeting and celebration for the APSF in 2010.
Well, welcome, you folks, to...
After Jeep, that's Jeep welcoming us, of course. After Jeep passed, Jeff Cooper and I did a tribute in the APSF newsletter. He was from North Carolina. Of course, he retained his Southern accent, even in spite of many years, decades actually, in Boston. Virginia, Duke Medical, residency at Penn, attending at the Brigham, and then for many, many years, chief of anesthesia at the New England Deaconess Hospital. He was president of the ASA in 1984, which becomes quite relevant to this whole story. This is the beginning, in the sense that he will tell us how he got into the subject of patient safety. This video from the 2010 meeting, because Jeep was unable to travel from Boston to California for the presentation, for the meeting at that time. So he had a video shot by our son Philip, who's sitting right there, in his study in his home in Boston. Philip was a videographer and now makes amazing creative videos. This is Jeep's message about the beginning.
And he asked me to speak on anesthesia accidents. I think what precipitated that request was that we'd had one at the Brigham recently in which a medical student turned off the oxygen rather than nitrous oxide at the end of a cholecystectomy and a black lady, and they didn't recognize it and didn't recognize the cyanosis until it was too late. And I found that subject, anesthesia accidents, intriguing, And from that time on in the mid-60s, I began to collect and review all the examples I could find, mostly from Boston, but also from the rest of the country. And
Jeep, of course, was the pioneering patient safety leader. In his early career, esophageal intubations, unrecognized esophageal intubations and disconnections were the main accidents that concerned him. And then he witnessed that problem firsthand with his own friend, daughter. She had anesthesia for a dental procedure, arrested and died at that time when an esophageal intubation was not recognized until it was too late. Jeep told that story frequently. It was a major stimulus, I'm sure, driving him to do this work. He often repeated his sad disbelief regarding how many patients he heard about from all over the country who were injured or killed by unrecognized esophageal intubations. It was a thing with him that he would talk about at every opportunity. Then in 1982, a very important television program is relevant to this story. This is the voiceover intro to that program. It has anesthesia, should not do it, danger, human error, carelessness, and a critical shortage of anesthesiologists, 1982. Nothing much has changed. And they talk about mistakes in administering anesthesia. This is from the program. The program was a deep sleep. 6,000 will die or suffer brain damage. And they talk about another case, nitrous oxide is turned up, oxygen turned off, brain damage. And they talk about Jeep Pierce's taking that opportunity as the incoming president of the ASA, and he had interest in safety, but this was his opportunity to turn the ASA's attention to this type of accident, which of course we'll hear more about. Now, this is very important. This is the tone of the 1980s. This is the front page of the Wall Street Journal. Remarkably colorful writing for the front page of the Wall Street Journal. Love, tragedy, revenge, beautiful wife, minor surgery, code blue. The anesthesiologist suffocated her brain and stilled her heart, accidentally inserting an anesthesia tube into her stomach instead of her lungs. Front page of the Wall Street Journal. Multi-million-dollar verdict against a good hospital. This is also the tone of the 80s. This is what we were up against. Demonstration. Doctor's mistake. Doctors bury their mistakes. Brain damaged child. Surgery did it. This was the milieu in which we practiced. Then, in 1984, Jeff Cooper, and Dick Kitts from the MGH convened the International Conference on Preventable Anesthesia, Morbidity, and Mortality. And that was a good meeting. I was able to be at that meeting. I had to sit in the second row, not at the main table, but I was there. And at that time, the idea was born, if you like.
there was so much disagreement, though, among the Americans and the Europeans about where to go next. Excuse me. We very early on decided we couldn't do this as a branch of the United Nations or anything such as that, because at the 40-some-odd of us meeting in Boston could not agree on anything. Certainly nobody in the United Nations would agree on an approach to take for safety in anesthesia. And sort of spontaneously, Jeff Cooper and others and I hit upon the term Anesthesia Patient Safety Foundation, and I think actually Jeff coined the term. But we chose that because we could have it completely separate from any other organization, including the very dominating ASA.
The history of the APSF is well documented. This is the front page of the 25th anniversary special edition of the newsletter from 2010, and shows pictures of Jeep, Bob Solting, and this is actually Dave Gaba, one of his mannequins. Jeep, of course, was the initial producer and director for the APSF. He was singularly dedicated. Anybody who knew him was inspired by his dedication and singleness of purpose. The anesthesia profession owes him a great debt, and the APSF appropriately honors his accomplishments and memory with this annual lecture. As far as my story, I love technology. I like to tinker. I love to fix things or create new ways to do something, hacks if you like. But importantly for this story, as a first-year resident in 1975, I was in one operating room, and on the other side of the wall was a second-year resident who was anesthetizing a 46-year-old African-American man having a hernia repair under general anesthesia. A routine thiopental and succinylcholine induction, initiation of nitrous oxide, halothane in those days, curare, and the attending was called out of the room. The patient suffered a cardiac arrest. He could not be resuscitated. It was discovered that the endotracheal tube was in fact in the esophagus. I will never, ever forget that day. I can see it right now. The resident's reaction, his mood, the department's reaction, its mood, this was an indelible, formative impression on me that comes back later. Now, at the same time, this is a related but coincidental, at the same time other things were going on, there was a new building being built in front of the Beth Israel Hospital, and a lot of construction. And before the building is opened, you test the gas pipelines and ultimately the water, it turned out, but the gas pipelines were contaminated with organic compounds and a fine gray metallic dust. A great confusion. How did this happen? So I got involved, the director of respiratory therapy got involved. We researched it, we figured out that some of the construction activities caused this problem, and that ultimately we flushed the system for many days to clear all the contaminants out of the systems. And the water was also contaminated with bacteria that flushed the same way. Then we published this article in Anesthesiology in 1977. Now, the construction project led to an accident, fortunately not fatal, and no patient was grievously harmed, when they breached the oxygen pipeline behind the hospital from the tank farm into the building with construction equipment. And that was, fortunately, not a catastrophic accident at the time, but it led the department chief, John Headley White, and the chief resident to do a survey of all the residency programs in the country about the potential, and had they observed any anesthesia or any accidents related to oxygen pipeline problems. And they published this paper in Anesthesiology in the same time period. Then, some years later, in 1983, I got involved, and this was my real introduction into catastrophic accidents, in the sense that, as you see here, the local oxygen company, which routinely would supply, local welding company, supply oxygen to the hospitals in rural areas. On that fateful day, the driver attached a tank to the system, but unfortunately it was argon instead of oxygen. So argon flowed into the oxygen pipeline into the hospital. 3 cases were started in the ORs, and they all promptly had cardiac arrests. Ultimately, 2 of those patients died. At the same time, there was a baby who was oxygen dependent in the nursery, and that ultimately, after a long struggle, that baby died. The Defense Department was appropriately scandalized and very concerned about this. They looked in the literature and found precious few publications about oxygen pipeline accidents. In fact, mainly from the Beth Israel in Boston, they called the chief of that department and asked, could he help? And he said, of course. And he assigned me and the chief of respiratory therapy to investigate this accident. They knew what happened, but how did it happen? Why did it happen? And why did it cause these catastrophic injuries and deaths? So we worked on that, discovered the answers to those questions, prepared a report, presented that report to the assembled chiefs of the major military hospitals and the Defense Department. And that was, as I say, my introduction into the world of, if you like, anesthesia patient safety. Then, the next year, the Controlled Risk Insurance Company, the captive insurance company that insures all the faculty at Harvard Medical School and the 9 hospitals, told the chiefs of anesthesia from the 9 hospitals that basically they were costing a fortune, in the sense that the anesthesiologists at Harvard represented 3% of the number of faculty, but generated 12% of the malpractice insurance payout, which was, they said, grossly out of proportion and a real problem. So the chiefs authorized the formation of this new risk management committee to study the issue and develop a plan. Dr. Headley White, having known of my experience the year before with investigating that accident, suggested to the chiefs that I be the chair of that committee, which did happen. The committee assembled, studied in detail all the accidents from 1976 through 84. The deliberations were difficult sometimes, spirited, contentious, but it was very clear that all the major accidents had a common theme: lapses in monitoring during the case, and particularly ventilation. Actually, all but one of the main cases was a ventilatory accident. That led to the Harvard Standards, published in JAMA in 1986, specifically detailed mandatory standards for minimal patient monitoring during anesthesia. Such standards had not previously existed, and resistance to the concept was anticipated but not seen, surprisingly, but that's the way it was. The idea being, of course, that early detection of trends and events would allow more time for prevention and mitigation of injury. And this, in turn, would help deal with the increases in malpractice premiums and lawsuits and settlements and judgments. This paper got a fair amount of attention. I was interviewed in national media, so on. And several members of the press, sadly, were much more focused on this line: about 2,000 or more may die of causes primarily attributable to anesthesia, than they were about our efforts to stop exactly that. But nonetheless, the message did get out, and we were pleased. The Harvard Standards are not recommendations. They're not guidelines. They're standards. They're mandatory standards. Why? Because they had to stick. They had to mean something. And we knew that if we created something that was published as a standard of care, it had to be followed, because the liability implications of not following a published standard of care for your care were horrendous, and everybody knew that. So therefore, it was a way to demonstrate to everybody in that time at the Harvard hospitals how important this was and how serious we were. It took a little convincing to get this idea across to the chiefs and the departments, but we did. The standards went into effect July 85. The last major accident of that era was the following month. None after that. The impact of what I call safety monitoring, the idea in the Harvard Standards, continuous monitoring of these critical parameters, was that my personal malpractice insurance premium between 1986 and 91 decreased by 2/3 what I had to pay to the insurance company. To me, that degree is a proof, is a truth. Remember, insurance actuaries are not charitable people, all due deference. They are not going to reduce my malpractice insurance premium by 66% unless there's a very good reason. And the reason was very simple. Far fewer major accidents, no major accidents, far fewer accidents of any kind, and less severe. So we didn't need P less than 0.05 as much as that's the gold standard. To me, this is proof, this is truth, based on that statistic. The Harvard Standards, as many of you know, formed the basis of the ASA standards for basic intraoperative monitoring. First introduced in 1986, I was fortunate to be the founding secretary of the Standards Committee. I later chaired the Standards Committee in the 90s, and that the standards came out of that committee, and later, at the end of the 80s, we finally mandated as a required standard pulse oximetry and capnography. We'll talk about that in a second. The Harvard and ASA standards inspired the work that eventually became the WFSA international standards, and a lot of the iterations since then. Summary: anesthesia care has been permanently, positively influenced everywhere. The Harvard standards emphasize behavior more than equipment, more than technology. The original standards did require continuous ECG, an O2 analyzer, and a disconnect alarm. But monitoring ventilation, while required, did not mention a requirement for capnography. It was suggested as an emergency standard in 1985. Likewise, monitoring circulation was required, but pulse oximetry was mentioned as one possible modality to do that over strong objections of one committee member who actually threatened to walk out because he believed at the time that that needed to be a mandatory standard even in 85, when we thought the profession wasn't quite ready for that yet. There is an incorrect belief that these two standards, that this standard mandated those two technologies in 1985, but that's not true. We did get some good press finally. This is the front page of the Boston Globe, and they talk about the safety standards saving lives, doctors to adopt the anesthesia rules which they use for the standards, and we were very pleased to see this kind of press. Then, as was mentioned, as I heard earlier today, in 2015, the late Paul Barish from Yale and his co-authors put together what they believed were a list of the 20 most important articles ever published, the so-called game changers. The criteria was publication that results in a revolutionary transformation that has been maintained in clinical practice since the article first appeared. That was their idea. Obviously, number one on the list is the introduction of ether in 1846, which allegedly the greatest contribution of American medicine to mankind, so on. Logical. We got number 10 on that list. And talking about G. Pierce as the inspiration, the article had key elements of patient safety, revolutionary to have a detailed standard, not a guideline. That was so critical to the idea. And it talks about the paper being a reflection of Pierce's vision, which changed millions of people, affected millions of people. The committee in Harvard went on to make more standards, pre-op, post-op, OB, and this published in a summary in the Journal of Clinical Anesthesia. Then I went on to go back and look from early 76 through 88, all of the anesthetics in the Harvard system. There were 1 million ASA 1 and 2 patients. And I found the important accidents, and basically unrecognized hypoventilation was by far the most common cause, as I said before. And they would have been prevented by appropriate responses to earlier warning generated by safety monitoring principles. Specifically, capnography would have been, but it was not mandated at the time, but it would have been the most effective monitor. The conclusion being that essentially all inevitable mishaps, whether they're technical or errors in judgment, during anesthesia case can be identified early enough to prevent patient injury. Standards went on to evolve, of course. By the end of the 80s, capnography and pulse oximetry, which had been emerging when the standards first came out in 85, became mandated standards of care, as they are and have been in the ASA standards. The great impact was that those two technologies, capnography and pulse oximetry, are vastly more sensitive than looking at or touching the patient. When I started training, to assess oxygenation in a Caucasian patient, you look at the color of the skin, and then you can look over the ether screen if you can see blood, see what color the blood is. That was what you did to assess oxygenation. Ventilation, I had an earpiece stethoscope connected to tubing that went either to an esophageal or precordial stethoscope, breath sounds, heart sounds, and frequently, if possible, I would rest my hand on the patient's chest to feel it moving with either spontaneous or controlled ventilation. That's the way it was in the 70s. And obviously, the technologies of capnography and pulse oximetry provide much earlier warning, rather than looking at the color of the blood, if you can see it, of problems, and therefore much more time for diagnosis and therapy. That's the real key. Early warning, appropriate diagnosis and therapy. Thus, continuous monitoring and early warning were the major reasons for the virtual elimination, as I've said, of intraoperative anesthesia catastrophes. Then we got the Wall Street Journal. Front page of the Wall Street Journal, again, 2005. Different story this time. Once seen as risky, changes its ways. Now offer model of how to improve patient safety and lower insurance premiums. Well, it's the Wall Street Journal. They care about the money. So they're interested in the insurance premiums. But they go on to talk, and the surgeons didn't really follow suit. They talk about anesthesiologists focused on improving patient safety. Less harm to patients would mean fewer lawsuits. Well, yeah. So, but that's important. That's the way they put it. And they talk about devices that alert doctors to the potentially fatal problems in the operating room. And they talk about medical errors as a leading cause of death in the United States. The story switched rather radically, and this is one of the positive results from our efforts. Today, basically all anesthesia records, paper or computer, have a checkbox for ASA monitors applied because it's the standard of care. And everybody should know what that means, but the ASA basic anesthetic monitoring standards, presence of qualified personnel. Unfortunately, every once in a while there's still a case report of an inappropriate, understanding their emergencies, but inappropriate situation where a provider leaves the patient unattended in a room, something happens, and there's a resulting injury and malpractice suit. Oxygen, ventilation, circulation, temperature, things that are all familiar to all of you. And the temperature I was very pleased with when we wrote, when changes are intended, anticipated, or suspected. Basically everybody. So that's how we got it in the original standards. These standards will persist for the ASA. There will be no new ASA standards labeled as that because of the liability implications. It's too great, it won't happen. But now we have practice parameters, which are sort of standards, but they're not called standards, which is actually important to the lawyers. In the beginning of this year, monitoring antagonism of neuromuscular blockade was the recent practice parameter. Very important, we'll talk about that in a minute. Brain function monitoring is not a practice parameter, it's a practice advisory, which is a step down in the intensity ladder at the ASA. But the APSF comes behind in last year, endorsing revised recommendations for patient monitoring, and specifically awareness prevention for inhaled anesthetics, maintaining 0.7 Mac or better yet, using an EEG with alarm. For IV anesthesia, EEG with alarm as a recommendation. Airway pressure, continuous monitor with alarm because of barotrauma issues. And post-op residual weakness, again, one of the major issues, specifically quantitative versus qualitative. Quantitative monitoring, and this has been covered. The advancements in quantitative monitoring, people I hope are familiar with the types of devices that are better than me putting my hand in the patient's hand and hoping I can feel the twitches. This is a little more objective, and it comes out with a real monitoring. Video laryngoscopes, same idea. Last year, Cochrane, for all patients, New England Journal for ICU and ED patients, basically showing that video laryngoscopes have a higher success rate than direct laryngoscopy. Well, oh yes. Should video laryngoscopy for intubation, for us, be a guideline or a practice parameter or maybe even a standard of care? Interesting question. We're not going to settle it here, but it is a good example of technologies stimulating and facilitating practice behavior. It will be less dramatic, but nonetheless, I believe it's a relevant analogy to the introduction of pulse oximetry in the late 80s because there was a demonstrated process improvement, but there can be no p less than 0.05 statistic that, quote, prove, quote, the effectiveness of pulse oximetry. Same idea will be for video laryngoscopy. It's logic and experience, but it won't decrease the malpractice insurance premiums the way it did in the 80s. There's a big misperception. Yes, compared to 40 years ago, anesthesia care is much safer. In fact, as I've said, intraoperative catastrophes have been virtually eliminated, which when you think about it is remarkable. What do? We give essentially potentially fatal doses of medications to patients, stop their breathing, and catch them by breathing for them usually, hopefully, while they are falling potentially to their death. Yes, there are many factors, but implementation of safety monitoring was undeniably the main contributor to that change. This is great. We're thrilled. It's wonderful. Intraoperative catastrophic accidents functionally gone. But what does that lead? It leads to complacency, something I'm very worried about, because the large majority of practitioners today were not yet practicing before the late 80s. They've never been involved in, seen, or even heard of a catastrophic intraoperative accident. In a way, that's great. In another way, I worry that it leads to a misperception about risk and thus a relaxation of vigilance, which is, after all, the ASA motto. It's a double-edged sword as far as technology inducing complacency. This is the classic image, the old days, reading the paper, doing crossword. Distraction for an anesthesiologist, it used to be the newspaper, usually the Wall Street Journal, if you listen to the surgeons. That was low tech. It's an issue of now, today, internet-enabled computer at every anesthetizing location, smartphones and tablets in every hand. Is this a risk or is it a benefit? Computers should be for the medical record, direct messaging, relevant material, but there is a debate about so-called entertainment, quote, reading. It's not reading anymore. It's surfing, social media, gaming, buying things on Amazon or eBay during an anesthetic. The debate will go forever. The consensus is usually negative, but it's also a legal issue, because if the anesthesia professional is being distracted by playing or buying on the cell phone, and there's an event, and everybody in the room testifies that, oh yeah, he was distracted, he was playing on his phone, that's going to be a problem. But there are very few accidents anymore. So it's a bit of a, what do you do? Well, I look back at this consideration of this issue. As far back as 1995, Matt Wenger, I don't know if he's here, but if he is, I congratulate him, for a long career as one of the best human factors engineers there is. He wrote an article, "Lack of outcome data makes reading a personal decision," states Matt Wenger. And he talks about no scientific data, personal opinion, or reasoned hypotheses based on data from other endeavors such as train engineers, nuclear power plant operators, air traffic controllers. Those are the people that have been studied as far as distractions causing decrements in their performance. And he goes on to say, this is a quote, "I would assert that most anesthesia providers read during these idle periods to prevent boredom," which he considered a potential positive thing. A lot of discussion, there was no clear recommendation. The APSF has followed up on this for a long time. Fall of 2004, is it acceptable to read in the OR because we can? Then Wenger has a study published in 2009 of an actual prospective study where he concludes in that study that anesthesia providers, even when observed, when they know they're being watched, read during a significant percentage of the maintenance period of many cases. However, that occurred when workload was low. It did not appear to affect a measure of vigilance. There are lots of other things. 2017, Wenger again, and another co-author we know well, talking about distractions in the work environment. Then the attorney, long affiliated with the APSF, writes that there's potential great legal implications, negative legal implications of reading or being distracted during a case if there's an event. But nonetheless, this is this year. This is now. This is the way it's seen still in our own publication. This in June of this year. Is that you? Personal electronic devices. Same issue in the monitor this August. Constant area of controversy. Fully gowned and gloved on the cell phone. And the old thing about anesthesia providers reading in the stock reports and so on and so forth, bad perception but the efforts were to ban this practice. Bans were issued. Enforcement was found to be very difficult. Here we are in the OR. Should you use your phone in the OR? This is a study, very interesting. Excellent references in this article in the Monitor. Self-reported distraction, never, 87%. Observed distractions, only 58%. Never. This is never 58%. So there's a bit of a difference, disparity. Self-initiated distractions, serious patient safety issues may occur. The debate continues. There will be no foreseeable resolution, I think. The addictive nature of social media and internet suggests to me that this technology has at least the potential to negatively impact intra-anesthetic behaviors of anesthesia professionals, and we're never going to settle it. Another aspect I think that is very important is the application of cameras in the OR. and I think that will significantly influence behavior. This is a very interesting study. It shows that the high-resolution cameras employed in this particular examination were able to read the labels on syringes and determine the number of milliliters administered, which allowed the system to track the doses of medications administered perfectly. It was exactly correct. So, independent of the likely prohibitive cost and profound medical legal implications, which would be enormous, should there be continuous multi-angle high-resolution audio-video recording of anesthesia care? I don't know. It's an interesting idea, and we could talk about that for hours. But in the intensive care unit, different story. This is I'm interested in, they have the tele-ICU at Penn. Will this ever become the tele-OR? I don't know. But the program at Penn is amazing. I highly recommend it to you. It was a subject presented at the Stolting Conference last month. It's the videos and slides are available on the apsf.org, and the Penn program allows them to, from a central location, effectively monitor patients in the ICU 24/7, 365, state-of-the-art. This is a two-way, high-fidelity AV connection for more than 450 ICU beds in a central monitoring location. It looks like the deck of a spaceship or a nuclear power plant operating room where they have all the dials and all the screens and all the information. One central location, incredibly sophisticated, very impressive. I urge you to look at this and see some of the pictures. Could this one day exist for anesthesia care in the operating room? I don't know, but I think maybe in the future. It's a very intriguing idea. But and it relate directly to smart alarms too. Smart alarms, logical next step. Safety monitoring, as I've said many times, is intended to provide the earliest possible warning, allowing maximum time to respond and prevent danger. The original idea, of course, was to pull all the signals and alarms together in one display. This idea has actually been around for a very long time. This is the 1988 abstract for this meeting, An Approach to Smart Alarms in Anesthesia Monitoring, talking about centralized consoles, interactive rules, dramatic evolution since then, a lot of research, development, testing, which now, of course, includes analysis and even suggestions for response. Going back, looking at 93, neural networks, 5 alarms wired together, if you like, to have a central display. Then the APSF comes this year with a different idea about smart alarms, making the sound, light, and vibration potentially tell you what the alarm is trying to tell you without you having to look at the screen or read the screen. Again, I recommend this article to you. But smart alarms would go to Michigan. Very important. Anesthesia Decision Support System. Kevin Tremper is the principal investigator. This is really, really important. Talk about information overload, potential to distract caregivers, a novel reactive agent decision support system with graphical human-machine interface was developed. And this is the flow chart. It shows down here, graphical visualization is the bottom line. And this is the graphical visualization, oh, I'm sorry, this is the alarms. These are the types of alarms that it can synthesize. It figures out what's going on and tells you, and through all these parameters that go in, and each one of these can be alarmed. All these various things can have an alarm sound, and they can make potential diagnoses like this. This is what it looks like. This is a normal situation where everything's green, all the input parameters and all of the factors. Then this is an abnormal situation in their system, showing, in this case, potential hypotension, which is here in red with low volume and low blood pressure. This was presented in 2018 in an online journal, and Kevin Tremper is a PI, and it talks here about the design was inspired by the multifunctional primary flight display used in modern aviation. This is Alert Watch OR from Michigan. This is a good example of the graphic, and it shows that, actually it shows something else interesting, that at time of incision there was only 0.4 Mach, but they're concerned in this particular example, hypotension, significant, for an extended period of time, and the system recommends or suggests possible unrecognized blood loss and recommends getting a measure at least a hematocrit. I'm also interested that they show that the kidney function is marginal. That's what the yellow means. And this is the kind of thing that is the wave of the future as far as smart alarms. This was presented in, it's hard to see, Anesthesiology 2018. It says down here, decision support alerts and risk prediction tools, and data to improve patient outcomes. The article was long and comprehensive. This is it. Kevin Tremper is the senior author. But the important thing is that the decision support system improved process measures, critical, process measures, but not perioperative clinical outcomes in their analysis preliminarily. This is 2018. But the potential's there, but it was very interesting to see that somewhat like the introduction of pulse oximetry, process improvement, difficult to prove outcome improvement. They took the Alert Watch system and expanded to alert in a different way to postoperative hemorrhage. And then in 2021, they present general care ward. In 2021 also, Alert Watch AC for all acute care patients at Michigan, having this kind of monitoring automatically processed. You had smart alarms. Let's make smarter alarms. Predictive analytics can make alarms smarter. Automated predictions. The best example, of course, is impending hypotension, maybe 5 to 15 minutes in the future, intraoperative hypotension. Requires, of course, an A-line, so allow the analysis of the waveforms. And this example, this has been a popular topic, waveform analysis, predict hypotension in anesthesiology, prediction of hypotension, intraoperative hypotension, Journal of Clinical Medicine, JCA, good review, hypotension prediction index. So this is something that's there. I don't know if it's clinically available to buy today, but this is very much real. Research, testing, validation going on. This is a step closer to artificial intelligence, real time in the operating room. It's close, getting there. But, as always, when this type of alarm sounds, the anesthesia professional must always evaluate, interpret, and then act accordingly. This is the behavior part. Technology integrated with behavior, because the final common pathway is always the human, so far at least. We don't have the robots quite yet. This is another excellent example. This is prediction of post-induction hypotensive prior to induction. It was tested, retrospectively tested, on a large group of surgical patients. All the input information leads, and this is Mike Mathis, I'll talk about him in a second. 10 minutes prior to induction, the system was 72% accurate, which they considered predicting the hypotension, modest performance. Mike Mathis from Michigan presented this last month at the Stolten Conference, and truly outstanding presentation. I urge you to go to the APSF website, look up these presentations. You'll be very, very impressed. AI, the final step, if you like. This is where we are today, limited memory. Past experiences inform future decisions, but it's vulnerable to outliers. Perhaps some of you already have ridden in an autonomous taxi here in San Francisco. Very popular, on the news all the time. When everything's normal, the situation is good, they follow the rules, they're very effective and safe. However, whenever there's a deviation, something new, construction in particular and emergency vehicles leads to confusion for the autonomous taxis, and there have been accidents, there have been injury accidents because of those kind of abnormal situations. So that's sort of the type of AI we're at today. Are we eventually going to get to theory of the mind and self-aware? Well, that's topics we can't get to today. Very interesting. Will there be ultimately the singularity, and so on and so forth? That's long in the future. But this is very active today. This is real. Active research, huge potential. If their system looks at this particular very challenging patient, elderly patient, multiple cofactors, and having a colectomy, the prediction was post-induction hypotension probability 98%. Okay? So you know what's coming. Then the system can evaluate the issue. The burdens are stroke, pulmonary complications, and acute kidney injury. And then the system considers the options. Do nothing, give a fluid bolus, give a vasopressor. And it evaluates all this in a complex algorithm, comes up with the expected burden. The least burden, as you see here, is to give a vasopressor prospectively, which is arguably something you might not choose as a first choice, but the prediction system comes up with this as a suggestion. Again, this is Mike Mathis from Michigan. I urge you to look at his presentations because they're just truly almost mind-boggling. Artificial intelligence is everywhere. Logical, next step, integrated technology, clinician behavior, far beyond that. Lead article, New England Journal this year, AI, machine learning, clinical medicine. JAMA, validation of the surgical predictions for adverse events, post-op adverse events, better than NISQIP. AI and health delivery, New England Journal. This is the very, very important paper. ANA this year about perioperative intelligence. This is the component of perioperative intelligence. As you see, the standard AI, machine learning, deep learning, neural language. This is what it comes out to. I really recommend, if you look up one thing, look this up. How can anesthesiologists use AI to improve perioperative outcomes? Very complex algorithm, obviously. Talks about imaging and matching and difficult airway prediction. But the thing that really caught my eye was the idea of, and I realize you can't read the fine print, but the AI system evaluating intra-abdominal pressure, temperature, ventilation, urine output, and come up with predictions for acute kidney injury. So all this is here. Improve outcome, identify the patients, early detection of complications, the opportunity to treat, early treatment and resolution. Does that sound familiar? I hope so, because that's analogous to what happened in the late 80s with safety monitoring. Early recognition allows more time for diagnosis and treatment, better outcomes. So it's cycle around again. Here we are again. It's basically the same ideas at an entirely different level, new level, higher level, future level, but this is functionally what happened in the 80s with the introduction of safety monitoring. Take it a step further. This is systems anesthesiology, integrating everything, as you see here, from the brain to the patients and all this, and come up with predictive models. The idea is predictive models. This is for ICU, of course, in this particular paper, predicting the future, but the idea being that you have the systems anesthesiology, perioperative intelligence, the intensivists with their input, and you can basically imagine, or they imagine, any patient in the world getting treatment from basically anywhere else in the world. And that's pretty advanced as far as the idea of what could be coming for in this case, the tele-ICU. But my question, of course, is, will this ever happen in the operating room? Will we ever have the ability to direct an anesthetic in another continent or multiple anesthetics in different continents at the same time from one central location? A very interesting concept, and I think this is a wave of the future. From here in San Francisco, UCSF, Kaiser, they did a study that allowed the AI system to evaluate fresh gas flow and anesthetic consumption, and they put it into the system and led to the reduced fresh gas flows and volatile anesthetic consumption. So all this tech is great, but it can never, at the moment anyway, replace the human behavior it must elicit. The tech is integrated with the behavior, elicits the correct behavior. Here we are again, the global put it all together idea here, all these factors put together, early recognition of problems, effective treatment together. As I said, early warning, practitioner recognized, implements response, which is the analogous thing, as I've said, will continue to say every opportunity, to safety monitoring in the late 80s, which of course was the main cause of the virtual elimination of intraoperative anesthesia catastrophes. I believe this concept of perioperative intelligence, with all the integration of all the tech, will become the standard of care. Don't know when, I don't know if I'll be here to see it, but I believe that this is the wave of the future, and this is where we're going. This will result a new era. It won't be as dramatic as the idea of my malpractice insurance premium being cut by 2/3, because that was very dramatic at the time. But it should still be of great benefit overall to the anesthesia profession and the patients, of course, that we care for. There are many other things we could be talking about, can't talk about today. Integration of technology behavior, good example, high-fidelity mannequin simulators and crisis research management training. Of course, this has been supported by the APSF since its very beginning. Jeff Cooper and Dave Gaba, APSF principals for decades, were pioneers and champions of this, and cognitive aids related, sort of. This lecture in 2014 was given by Dave Gaba about cognitive aids in the OR. Now we're beyond the cardboard flip books, and we're talking about computerized protocols either in the information management system, in a personal electronic device, or on the internet. Medication errors, always a topic for the APSF, been discussed for decades, will continue to be discussed. It's been the subject of initiatives, conferences, recommendations, so on and so forth. Huge role for tech, huge role for using AI eventually to, can we eliminate medication errors the way we eliminated intraoperative catastrophes? I have a couple of nodding heads over there, that's great. I would like to believe that too. Again, I hope I'm here to see it. Handoffs, a very common topic, was the award today. Independent of the various risk-benefit issues, there's a lot of research on how to apply tech, whether it's in your hand or in the anesthesia system record. It's a good example of the potential usefulness. You talk about the pictures of people with cell phones in the OR. You have the person being relieved and the person taking the handoff. Each has a cell phone, has the same list. They're connected, Bluetooth or whatever, and they go through the checklist for the handoff. I think that that's something that's very doable. It should be available. I don't think it's available yet, but I think it should be, because I think that's a good example of tech having a huge positive impact. Human error, of course, is human. No anesthesia professional ever starts the day with the intention of causing a patient injury accident. Safety monitoring, my theme, relies on the vast enhancement of our senses with sensitive electronic computerized monitoring to provide the earliest possible warnings and maximum time to react, diagnosis, and treatment. The goal, of course, avoiding injuries. And this is enabled by the integration of technology with human behavior, as I hope you've understood for the last few minutes. But so far, it's always the practitioner final common pathway to keeping the patient safe, taking all the output, if you like, from the tech, because we don't yet have the robots to take over for us. So we have to be the ones that take all the information and apply it. There's every reason to believe that we can do this, and I think it will continue to improve. However, we must be vigilant, always. Our inspirational founding leader, G. Pierce, for whom this lecture is named, reminds us graphically that there will always be human error.
By saying that all of us are guilty of human error from time to time. And I do remember, and I've told this several times before, that they installed an ATM machine in the cafeteria at the Deaconess Hospital. Inevitably, I left with the money and forgot to pick up my card. And somebody would hunt me down in the cafeteria and hand me my ATM card. That happened apparently to enough people that the bank changed around so that you couldn't get the money out until you took the ATM card out. That's fine. I thought that was a very improved way to run the machine. So what did I do? I took the card and left the money, which is a prime example of human error.
You may not have got the last word. The prime example of human error. That's Jeep. I appreciate your attention. Thank you very much. I see that my time is up. I have to stay here? You can do this now?
Yeah.
Okay.
Well, there's two now.
Oh.
Yeah, so thank you for an inspiring lecture. Generally, the APSF awards the Pierce Lecturer a plaque this evening. The ASA has also given me a certificate here for Dr. Eichhorn, and it reads as a distinguishing lecturer for the Ellison C. Pierce Lecture, Integrating Behavior and Technology for Anesthesia Patient Safety. Thank you all for your attendance, and thank you, Dr. Eichhorn.